Hello, welcome to the American Lung Association's Cessation Technical Assistance recorded presentation series. This is the first presentation, What is a Comprehensive Cessation Benefit? We hope you enjoy the presentation. Your speaker today is Jennifer Singletary, the Director of National Health Policy at the American Lung Association. Jennifer, now to you.
Thanks. The learning objectives for today's presentation are as follows. Users will be able to list tobacco cessation treatments and identify how they help a tobacco user quit. They will be able to identify a comprehensive tobacco cessation benefit and identify common barriers to accessing a tobacco cessation benefit. So the first thing to know in understanding what a comprehensive cessation benefit is the Public Health Service Guideline. This is essentially the Bible for tobacco cessation. This document was last updated in 2008. It's called Treating Tobacco Use and Dependence. It was written for clinicians and health systems, and it has recommendations for clinicians in it. And it's based on a comprehensive review of evidence on what works to help smokers quit and what treatments are effective. The Public Health Service Guideline recommends 7 types of medications and 3 types of counseling. And those medications and counseling are on your screen. They include nicotine patch, gum, lozenge, nasal spray, and inhaler, and bupropion and varenicline for the medications, and individual, group, and phone counseling. And we will get into each of these treatments on future slides. One thing to note before we get into each of the treatments that are recommended is what is not recommended or what is not part of a comprehensive cessation benefit. This includes medications that are not FDA approved for smoking cessation, medications and counseling types or other treatments that are not recommended in the Public Health Service Guideline. For instance, hypnosis, those types of treatments, they are not recommended in the guideline. Additionally, anything that is classified as a tobacco product rather than a cessation device or treatment is not included in a comprehensive cessation benefit, and that would include e-cigarettes and smokeless tobacco products. They are not part of a comprehensive cessation benefit. The first type of medication we'll talk about is nicotine replacement therapy, very often called NRT, abbreviated. NRT comes in 2 varieties, over-the-counter and prescription. Over-the-counter meaning you don't need a prescription and you can just walk into a store and buy it without anyone's permission. And the NRT that is sold over-the-counter is the nicotine patch, nicotine gum, and nicotine lozenge. Prescription varieties of cessation medications include the nicotine patch, the nasal spray, and the inhaler. You'll notice that patch is listed on both of these lists, and that is because there are forms available over the counter and also prescription. The next medication is bupropion. That brand name is called Zyban. There's also another brand name for the same medication called Wellbutrin, but that medication is approved to treat depression. Zyban is the brand name for the smoking cessation drug. This drug is also sold as a generic, so there are many generic versions of the drug. Bupropion is non-nicotine. It does not have nicotine in it. It is prescription only, and its function is to decrease cravings and withdrawal symptoms of tobacco users who are quitting. The last medication for smoking cessation is called Varenicline. Its brand name is called Chantix. This medication is not available as a generic. It is also a non-nicotine drug. It does not have nicotine in it, and it is only sold with a prescription. Varenicline acts on the same receptors of the brain that nicotine does and essentially blocks nicotine's effectiveness. It reduces cravings and withdrawal symptoms. If you notice the squiggly lines on this slide, they're meant to illustrate the top squiggly line is essentially a smoker's cravings and withdrawals as they go through their day. Maybe when they're trying to quit, there'll be high peaks and low valleys. The point of Varenicline is that it evens out. It makes the valleys higher and the peaks lower, so that the cravings eventually disappear. Now we'll talk about cessation counseling types. As we said before, it's group, individual, and phone counseling, and we'll talk about each one on successive slides. The PHS guideline says that the two most important elements to a cessation counseling session under any of these types are discussing with the patient their problem solving and skills, like how to avoid their triggers or how to develop coping skills when they're having cravings. The other element is social support, which is simply giving them encouragement, telling them they're doing a great job, reminding the patient of why they're quitting smoking, things like that. So those are the two important elements of any type of cessation counseling, and we'll get into each type in a second. Individual counseling means face-to-face in the same room with the tobacco user. Insurers usually reimburse individual counseling directly with the healthcare provider. Insurers choose which provider types are eligible. The Lung Association recommends that as many provider types as possible are eligible for this reimbursement, like dentists, OBGYNs, midwives, behavioral health providers, as well as your primary care physicians and the doctor that the patient sees all the time. Often individual counseling with a healthcare provider uses the 5 A's model, and those A's are ask, advise, assess, assist, and arrange. Next is group counseling. There are several different options for a health insurer to cover group counseling. One is to, like individual counseling, reimburse the healthcare provider directly for providing it. So say a doctor decides to start a class as part of his doctor's office or his clinic, and the insurance provider could reimburse the healthcare provider directly. But there are other ways to do it for group counseling. The insurer can also work with a vendor, like a nonprofit, a hospital. There are also for-profit vendors of group counseling, and they can reimburse the vendor directly and send all the patients who want to quit smoking to the vendor. The health insurer can also allow patients to choose their own program and then reimburse the patient directly for the cost that they paid, the registration fee or whatever they're paying for the program. That's a good way to do things because it allows patients to choose which program to go to, which one is convenient for them. However, this is not advisable for plans that are serving primarily low-income patients because those patients might not be able to pay costs up front and they might decide not to get counseling. The last type of counseling is phone counseling. This obviously occurs over the phone with the patient. Again, there are several different ways an insurer could cover phone counseling. One is to create a contract and a partnership with the state quit line. Each state has a publicly and privately funded quit line. And that is open to most people in the state and already exists, and it has good people working at it. So that is one great option for a health insurer, is to contract and partner with the already existing state quit line. But there are other options too. There are other phone cessation counseling vendors. And some health insurers also send folks to their nurse hotline or their case managers or some other staff person at the health plan to deliver phone counseling. This is a fine option as long as the person answering the phone is actually trained in tobacco cessation counseling. Now let's talk about the barriers to access to avoid when designing a tobacco cessation benefit. The first barrier to avoid is cost sharing. Cost sharing can include a co-insurance, which is when the patient has to pay a certain percentage of the treatment when they get to the doctor's office or the pharmacy. This also includes a deductible, which is when a patient has to pay out of pocket the entire cost of the treatment until they meet their deductible, and then their insurance kicks in and they pay less. And the most common form of cost sharing is a copay, which is a set amount that the patient pays when they are filling a prescription or getting a treatment. Cost sharing can often vary based on whether it's a generic or a name brand, if we're talking about medications. Also, the preferred status. So if the medication is on a preferred drug list, sometimes it has a lower copay or less cost sharing. And obviously, cost sharing can vary based on the cost of the treatment. The problem with cost sharing is that it can prevent patients from getting the treatment because maybe they can't afford the copay or the deductible, or even if they can't afford it, quitting smoking is really based around motivation, and having to pay up front for a treatment can make the smoker lose motivation. And cost sharing has been shown in research to reduce the use of a treatment. So we don't want cost sharing on tobacco cessation treatments. The next barrier is prior authorization. This is when the patient or the provider has to essentially ask the insurance company whether they're allowed to administer the treatment or to get the treatment, whether that be a medication or counseling. Authorization must be given before the prescription is filled or the treatment is given. If the authorization does not come through and the patient decides to get the treatment anyway, they have to pay the full cost usually. Or they can decide to go back to their doctor or simply not get the treatment, which is the problem. So prior authorization can slow down the quitting process and discourage the smoker from getting treatment. So they might decide to give up and not quit at all, or they might decide to give up in treatment and just try cold turkey, which we know is not the best way to quit. Duration limits are when a plan limits the amount of time a patient can take a medication or the number of sessions they're allowed to have during counseling. These kinds of limits can force a patient to stop treatment before they are ready, which can lead to a relapse. So say the smoker is doing pretty well with their quit attempt, but they get to this limit of they can only take 3 months of the medications, and they're not quite ready to get off the medication. Well, they either have to start paying themselves for the medication, or they might risk a relapse. So these are very problematic, especially when we're talking about medications, when the limit is smaller than the amount recommended and approved by the FDA. Sometimes health insurance plans also limit quit attempts. These happen either an annual limit, so the plan will say there are 2 quit attempts per year, and if you need to try more often than that, you have to pay for it yourself, or even worse is when a plan has a lifetime limit. So you can only try to quit with treatment, twice in your lifetime, and then you're done and you have to pay for it by yourself or forego treatment. And these are particularly troubling because we know that most smokers make several quit attempts in a lifetime. They also often relapse. And quitting is very much a process, and you don't want to cut that process off before it's really been successful. Dollar limits are pretty self-explanatory. It's when a plan limits the amount that they will pay for a cessation treatment. These are often annual or lifetime. And so, for instance, a plan will say we will pay up to $500 for you to quit smoking, but then once you reach that amount, you have to pay for everything yourself. Stepped care therapy is when a plan requires the patient to try one treatment before they can try another one. Often, step therapy is implemented to require the patient to try the cheaper medications or the cheaper treatments before moving on to the more expensive ones. And the bad thing about step care therapy is that it requires failure. Again, when we're talking about quitting smoking, this is very motivation oriented. And this kind of policy requires the patient, say they come in and they want Varenicline, that's what they and their doctor have decided they should take. But the insurance company says you have to try the patch first. And you have to fail on it. So you have to fail in your quit attempt in order to get the medication that you want. This is obviously not ideal. The last barrier that we'll discuss is requiring counseling. Now, this might be a little counterintuitive. We know that the best way to quit, according to the PHS guideline, is pairing medications with counseling. That will give the smoker the best chance of successfully quitting. However, the Lung Association recommends that insurance plans encourage and cover cessation counseling, but that they not require it, because there can be barriers to actually meeting this requirement in order to get the medications. And some of them are listed on your screen, such as time to go to the counseling session. A lot of patients may work 2 or 3 jobs and they just don't have time to do counseling. Getting childcare can be an issue. Lack of minutes on a phone plan. The location might not be convenient. It might be that the requirement is they have to go to a program that is 2 hours from their house, and that's just not going to be very motivating for them to go. So the recommendation is that counseling be encouraged and definitely covered, but not required in order to get medications.
Now we will address some commonly asked questions. Jennifer, do plans really need to cover all of these treatments?
That is the American Lung Association's recommendation, as well as the recommendation in the Public Health Service guideline. Every smoker is different and every quit attempt is different, and different treatments work for different people. Quitting is not a one-size-fits-all process. So tobacco users need access to all of the treatments that are recommended and proven to be effective in order for them and their doctor to come up with the right plan to quit.
Thank you. So you listed a lot of barriers. What are the most important barriers to remove?
Well, the Lung Association would certainly consider all of them to be important. However, I can tell you which barriers have particularly a lot of evidence behind them as being a bad thing for someone who is quitting smoking. And the first one is cost sharing. There is a lot of evidence showing that putting a copay on a medication particularly, but also counseling, but putting a copay there will limit the utilization of that medication versus if it were provided for free to the smoker. Another barrier that has a lot of evidence behind it is prior authorization. There are definitely studies showing that if you require prior authorization for a medication, the tobacco user will use it less or even give up and not fill any prescription for tobacco cessation. The other particularly egregious barrier is those lifetime limits, because a tobacco user could be on an insurance plan for a long time, for many, many years, and they use those 2 quit attempts, say, and that's it, and then the plan doesn't cover anything after that. So that can be a real problem if the smoker relapses or if they need to try several times to quit.
Thank you. If you have additional questions, please feel free to email us. Our emails appear on the next page. Thank you for listening to this presentation. If you'd like to learn more, we have additional presentations on our website. The next presentation in the series is, So You've Got a Tobacco Cessation Benefit, Now What? Additionally, on that webpage, you will find various fact sheets that are associated with this presentation and we believe may help you in your work. If you have questions that were not answered or that you have surrounding the presentation, please contact us at cessationta@lung.org. Thank you so much, and we look forward to you watching the next webinar.